Hi everyone, my name is Paul Nichols. I'm the colorectal MDT lead in University Hospital Southampton. I've been asked to talk to you today regarding the faster diagnostic service and how it's been developed in UHS, mainly because we're a pretty large centre and we've managed to achieve some pretty good data so far. I also have a role within the Wessex Cancer Alliance as a clinical advisor for colorectal, so I'm involved in a lot of their services. I'm going to start by thanking some people in advance of the first slide and also apologise for not being with you today because I have to operate. But I'd like to thank Robert Radford particularly, who has helped, he's the programme lead for the FDS, helped to put these slides together, and Jane Winter, who's the lead nurse for the Wessex Cancer Alliance and used to be a colorectal specialist nurse, in fact, a colorectal consultant in Southampton, and in fact has been fundamental for us to deliver this service within Southampton itself. In terms of the first slide, this slide just shows the data for colorectal nationally by Cancer Alliance, and is the very first month, so this is April's data. So this is when the data obviously went live. Wessex sitting number 2. I have to say, prior to this, we were probably number 1, but clearly as this is the latest data, this is what we wanted to use for today. And you can see, though, that there's a massive spread across the country. And it's really important that we try our hardest to deliver best practice across the whole country to obviously get the standard achieved for all our patients. I just wanted to highlight, unashamedly really, that the position of Southampton. So we're the top line. The other trusts, 1 to 5, are other trusts within our patch. There's a couple of others obviously still doing pretty well in terms of achieving the standard over a number of months. Southampton had a very bad January. That was peak second wave, and I have to say we had a bit of a hit at that point. But before that, we were already achieving the standard in over 75%, and in fact, as you can see, nearer 90% in November last year. And this is peri-COVID, of course. And this is with the second highest. So for our region, we see about, this is an average of this 6 months, 318 a month. At the moment, we're averaging a bit more than that, or rather we're seeing somewhere between 350 plus, whereas we used to sit around the 250 mark pre-COVID. The trust number 2 here is one of our smaller trusts, but again, just shows what you can achieve. But it also shows that across our region, across our alliance, we still have quite a lot of work to do. And that's where Sally and myself come in to try and, as best we can, spread best practice to achieve good numbers across the whole patch. So how have we done this in Southampton? These slides, I'm going to have to say, again, I've already thanked them in advance, but Jane Winter put most of these together because, as I said, she actually set up the service in Southampton when she was our consultant nurse here. What we did was we looked at the 28-day pathway and the timed pathway in particular, which I'll bring up at the end of the talk. And that's how we tried to focus. And you have to focus 100% on the front end of the service. And to do that, we set up nurse-led clinics at UHS. This has been going on for many years, in fact over 10 years, and initially was there predominantly to reduce the consultant time in follow-up and allowed our nurses to gain more and more experience in seeing patients face to face. We do have to work together as a whole team, and there's no doubt you can't achieve anything without doing it as a whole team. The most important thing I think to achieve this is to see your patients as quick as you can. If you can start the timed pathway immediately, you will save time at the end. So we try and have achieved predominantly a 2-week wait clinic every single day. So the vast majority of our patients certainly they go through little glitches when the numbers suddenly go up, as they did intermittently through COVID. But most of them are seen, and that's virtually most of them, but they're seen effectively within 7 days, and if we possibly can, within 3 days. So we have 80 slots per week available just for that front-end service. Originally, these were all face-to-face, but now they're pretty much 100%, well, that's not 100%, they're pretty much telephone. Patients that have to come and see us face-to-face are WHO poor functioning, or have communication issues, or have a definite mass, in which case they are seen face-to-face, usually by a consultant or under consultant supervision. So the vast majority, though, of a nurse-led telephone service. It's a triage service, effectively booking straight people into endoscopy, providing the patient doesn't have any reasons why they can't go to endoscopy, in which case they might go on to a CT pathway, or indeed will be discussed with a consultant if they're not fit for anything. Again, I come, as Jane has written in this last comment, the importance here is the clarity of the process for the whole team. Everyone needs to know we're working to the same standard. We do, and we're able to generate some CT slots within 48 hours. So our CT department have guaranteed as best we can, and certainly pre-COVID, we're doing it extremely well within 48 hours. Again, during COVID, we've had some slippage. It's very variable. What we do get, and again, I think is absolutely vital, is hot reporting, and almost all of our CTs are reported on the day, or certainly within 24 hours. We also have dedicated MRI slots, PET slots too, although I have to say the PET service at the moment is under huge amounts of pressure as different services are using it. We don't need it as much in colorectal, but there are patients where it's important, and that's often in follow-up rather than new patients for colorectal. Anal, we do use it a lot. These slots are protected, and then if they're not used, they're released, and they can be used by the department for inpatient slots, and they're never wasted. As we mentioned earlier, all patients are risk assessed, and only those very high risk patients are seen by the consultant. And indeed, we have an age cut off. Initially, it was 80. Now it's gone up to 85. So anyone over 85 is still seen by a consultant. And again, this keeps slots available for rapid turnaround for all the other parts. So as soon as we have results, patients are able to come back and see the consultant to talk about their treatment plans, hopefully, and nearly always with a CNS. Again, partly a result of Jane Winter and her CNS team, together with the consultants. It's really important that you start to book patients for their surgery even before they've completed their tests, or certainly pencil them in. Now, there may be some movement of patients, and we may have to swap patients around at times. But if we can start working on their end bit of the pathway right at the beginning, it's a bit like planning for discharge. As soon as a patient's admitted onto a ward, even though that might be a week away, if you start planning for it at the beginning, you have much more chance of achieving it at the end. CNS meets the patients at the diagnosis. So that's often in endoscopy, and endoscopy have a direct link to our nursing team, who will come and see all our patients at that time. And then we'll follow them up and put them into the consultant's clinic as necessary, and get their investigations underway. There is some minor disadvantages. We can't direct book our colonoscopy, but having said that, our booking team now again did have some hiccups. There was some hiccups in terms of prescribing bowel prep, but once that's all been ironed out, and now we prescribe it electronically, the endoscopy department is extremely efficient at booking patients. So most of them are booked well within a week. So challenges, and these challenges I think were more about COVID than anything else. We tried as best we could during COVID to reduce the amount of cancellations. 2-week waits were pretty much protected. The nurse-led clinics weren't, those nurses weren't redeployed. We were both fortunate and lucky in Southampton. We didn't get the first wave. We were able to protect some of our services, and certainly the cancer services. And therefore, despite the numbers going down in terms of referrals, all of them were seen and quickly triaged. I think there was actually a question raised in advance of the meeting about, do we fit test, as in the COVID guidance? And in fact, this was mentioned when we were putting the talk together, in that during COVID, or certainly during the peak wave, when endoscopy services basically had to close for a short period while we were understanding what PPE both we needed and was acceptable, we were using fit testing at that point to triage our patients using the national standard. That meant that all our patients, even those with fit negative, were held in a virtual system, but they were deferred if they were fit negative, and then everyone else was triaged in terms of their level of fit. Now talking about the steps we've taken to try and overcome some of these challenges. So endoscopy, we had to look at the whole booking process. So peri-COVID was a pretty difficult time for everyone. We had patients on lots of different holding pathways, some 3 months, some 1 month, some needed to be done urgently. We tried to get fit tests for all patients very, very early on. That proved, again, quite difficult. We had to physically get the fits out to patients and then get our results back. And we were doing that in secondary care. This wasn't a primary care thing, so it actually became quite challenging. Since then, we've been trying to proactively get fit for all our patients, because although at the moment we're not using fit as a absolute criteria, certainly if the service became under any further pressure, we could immediately sort of reenact the situation where those with a under 10 fit, which does carry a very low risk of having bowel cancer, then we could put those on a holding pattern again. We were able, and we were quite lucky again in Southampton, we had a number of off-site areas which we could use to get through the COVID crisis. So we had a department that was an ISTC that we were able to borrow or take over, and we were able to do a number of patients there. We weren't able to do our shielders, our real heavy shielders early on. We eventually were able to open up service at the Spire Hospital, which we'd also taken over to help our cancer delivery, but that meant it was even in a better protected area for these patients. As I suspect most of you found, or those of you working in colorectal, there were a lot of patients who were extraordinarily scared about coming to a hospital, particularly even if they had a positive fit. It was quite surprising that some of them had obviously been genuinely scared by the pandemic and wouldn't come despite multiple calls. And in fact, going forward, that became, and still is to a degree, a little bit of a problem, in that there are still patients who kept deferring. And all that does, of course, is put more pressure on the admin services and those that are trying to track the patients to make sure that we're not missing any. It doesn't help with our numbers. It makes our diagnostic numbers fall in terms of achieving the target, but that's why we'll, for this service, we'll never get to 90-95% regularly, I don't think. I think 75% is definitely achievable for the majority. So I've just got a few tips to talk about. How can each and every one of us use these things that we've done in UHS to help others? I think self-evident, but it is a whole team. You need a whole team. You need booking clerks, you need MTT teams, you need radiology. The model only works if the whole team commits to it. It was a surprise. There's a tip here at the bottom that I've written 2-week wait ? I raised this to the team at the Cancer Alliance because it absolutely astounded me that when I was sitting in a meeting as the MDT lead and we were talking about how we might get our 2-week wait patients through the service quicker, the endoscopy team very clearly said to me, oh, we're trying our hardest to get all the patients booked within 2 weeks of the referral. And it just shows that despite the fact that this has been around for years, there was still a misunderstanding of what 2-week wait meant. And I'd be fascinated to know how each and every one of your departments understand what 2-week wait means. Radiology, again, we changed the title now. It's not called 2-week wait. It's called, they're called cancer pathway patients. So now everyone sees cancer pathway in radiology, and they know that that's got to be done ideally within 48 hours. Endoscopy are still using, because our electronic booking system still calls these patients 2-week wait patients, even though they will change. And I think changing to FDS patients will be better because it will effectively reset people's understanding and will take away this 2-week wait, thinking that 2 weeks means 2 weeks. Absolutely astounding, to be honest, particularly for those of us who understand what it really means. Number two, as a top tip from Jane particularly, was the fact that the nurse-led service has really allowed us to achieve huge, bigger numbers. I think some of the nurses during the COVID were shielding themselves, but they were able to work from home and continue to do it. Patients found it and have found it really very acceptable. When we first started doing it, it was some of our senior nurses who were doing it felt that it might not, they didn't think they were going to like it. But in fact, as they've moved into it and got used to it, they find it actually very rewarding. The patients are very good on the phone. They also can have a second pickup phone call, and that's easy to do if you already had the first call rather than a face-to-face. But don't forget, services are very fragile and you need a whole team. We lost a couple of members of the team through illness, not through COVID, and we've obviously, not obviously, but we have patients on maternity, staff on maternity leave. This does put a pressure on the service, and therefore you need multiple members of the team that can do multiple parts of the pathway, so that they can help step in times of crisis or need. Really important you do have tight protocols. Really important that you time that pathway so that you, again, as I mentioned earlier, concentrate on the front end. Because if you concentrate on the front end, you'll achieve so much more at the back end. We've also had some funding from the Alliance. This has helped to set up daily clinics and the clinical engagement again, and we need to make sure we make the best use of all our funding to make it better. And the final point I added just yesterday actually was, and I think this is a very significant way that you may well be able to achieve higher numbers in terms of, I don't want to say ticking the box, because it's not just ticking the box, it's about the patients getting their diagnosis. But what we have added to, we have an electronic endoscopy system, which I suspect most departments have now. I don't know if anyone doesn't. But part of the outcome is you have to do, if the patient has been referred on a 2-week wait, an automatic box drops down and says cancer diagnosed, cancer not diagnosed, or cancer undiagnosed, and then it also says patient informed. And it's important that you, as the doctor, and then or the nurse, because often these are done by nursing endoscopists, if it's a 2-week wait and you have proven the patient doesn't have cancer, if you tell them there and then, and make sure you again do it at discharge, you've achieved your diagnosis. That's the important thing. They don't have to come back to clinic. They don't have to wait for a second telephone. And if they've got cancer, you've actually told them that they've got likely cancer. That probably, I mean, that does also tick that box in terms of telling the diagnosis, although we're still waiting for histology. So it's a slight moot point that needs to be clarified. But in terms of getting those patients that don't have cancer, clarify that they don't, it's really an excellent way of dealing with the vast majority, of course, of our 2-week wait patients who don't have cancer. So the earlier you can give them the information that they're clear, the better for both achieving this standard, but also better for the patients. And then finally, this is a slide that most of you will have seen. It came from the 28-day setup team, and it's something that we can leave on the screen to perhaps talk through the rest of the workshop when I'm not available. But as you can see, at the beginning, day 0, you get the referral. Day 0 to 3, clinical triage. If you can possibly do your triage before the 4th day, you're already well ahead of achieving your 28-day target. You know, if you can then go straight to tests without having to see them, without any subsequent tests. So again, really important, your 2-week wait form has bloods incorporated in it, because that may cause a delay in your being able to deliver them the bowel prep. But again, if you can get this done within 14 days, you're really likely to achieve your target, certainly for those patients without cancer. And even with cancer, you've got a very high chance to be able to get them through the MDT by the 3rd week, and given the final discussion after the MDT to the patient well within the 28-day standard. So it can be done. We've done it in a pretty big hospital, you know, with 300 to 350 patients every month. All you need to do, though, is keep on top of it. You've got to be doing it all the time, because if you're not, you suddenly drop behind. And at the moment, just again, I suspect it's happening everywhere, but we're having to do relatively short-term, organised extra 2-week wait clinics. We need to get that front end done, not just to achieve this target, but to get our patients through the system as quick as we possibly can. And that's partly because of the numbers that have gone up quite significantly due to COVID. Thanks for listening. Enjoy the rest of your session.